Really pleased to talk to everyone today. Before I turn it over to today's faculty, Dr. Ann Lake and Leslie Stovall from Wake Forest Baptist Medical Center, to talk more about billing and coding tools for your FLS program. Just want to do a few introductory slides. Maybe if this is going to be, here we go. So just a little overview of MBHA. Hopefully everyone on the line knows who we are and what we do. We've been around since late 2010 as a public-private partnership, bringing together all the sectors around bone health. We currently have 55 organizations around the table, 30 nonprofits, 20 private sector members, and 5 government liaisons. Through our membership, we can reach over 100,000 healthcare professionals and 10 million consumers, really driving bone health and prevention, improving diagnosis and treatment, and enhancing research, surveillance, and evaluation, which are all things that we're certainly driving through our Fracture Prevention Central and Fracture Liaison Service work. So our vision is to reduce bone breaks 20% by the year 2020 and really see the FLS model as the solution to that care gap. About 3 years ago, we launched Fracture Prevention Central, which is kind of one-stop resource on fracture liaison service programs, really to help both healthcare professionals and administrators understand more and help to implement a FLS model. Compiled materials and case studies from a number of leading programs, both here in the United States as well as across the world, that are implementing FLS programs. Have now sponsored over 30 webinars on various aspects of the FLS model. Here are the next couple coming up. August 16th, something we're doing in collaboration with the International Osteoporosis Foundation, how to get best practice recognition for your FLS program, which will enable you to get on that worldwide IOF Capture the Fracture map. The next one coming up is not until October, patient materials for a diverse patient population that will feature Kathy Williams from the Southern California Kaiser Permanente program. So as you can see, we've got all the links to all the webinars available, and all of these are available on demand, both videos of the slides as well as the slides themselves on those 2 links. The newest thing that we have released, actually just last week, which was enabled through grants to the Research Triangle Institute and the University of Alabama, Birmingham, was a fracture liaison service return on investment calculator that we've developed really to help folks make that granular business case, which, what you'll need is some of your own data on historical fracture rates. We also give you a nice, pretty expansive list of potential revenue you may generate from your FLS in terms of DEXA and other screenings, office visits, labs, infusion services, etc., which will help you really calculate, even with some of the front-end costs in terms of the FLS coordinator, other pieces, but then looking at the fracture reduction and, driving fracture prevention, really, what your bottom line looks like. So certainly very needed and useful for folks that are making that specific business case to their institution, their hospital administrators, C-suite folks, because we know that's been a challenge to, we've had some, I'd say, some okay return on investment information and business case information on the site, but this will really allow you to use your own data as well as enable you, if you don't have all of the data that we're looking for, to kind of enter more simplified data to help make some of this estimates. So as you can see, there's the 3 links to: 1, download the return on investment calculator, the webinar that we sponsored last week, which is available online, and then we did a separate kind of truncated video where we took just the user input screen walkthrough and created a separate video. So if you want to just kind of sit with your calculator and see exactly what the inputs are, what you need to pull together, that's a nice tight, probably 14-minute video out of the 1-hour webinar from last week that just shows you really how to use the calculator. And then last one, I'd also talk a little bit about the one-on-one consult service, which we launched about a year ago, to really allow folks, especially that are stuck, if it's implementation, making a business case, patient identification, case finding, whatever it might be that needs a very specific conversation with a national FLS expert, such as Ann Lake. Leslie Stovall also is working with us as a consultant on reimbursement issues. Andrea Singer, Mary Oates, other clinical experts are working with us on this. We can connect you directly to those folks to have a one-on-one conversation, really by just going to your Fracture Prevention Central website, clicking on the one-on-one consult page, filling out a short questionnaire just to make sure that we're pairing you with the right expert, and then we will help facilitate that conversation. And then lastly, I just wanted to mention something hopefully everyone has seen, and many of you I hope has returned, which is a national FLS survey that we pushed out in July, really with the goal of trying to quantify the number of FLS programs in the U.S., along with some of our internal data in terms of folks that we know are running FLS, to start to come up with a U.S. map, I think, as well as to be able to show moving forward as we get more and more enthusiasm around the FLS model, growth in the number of FLSs around the country. So if you haven't participated in, the link is right there, the SurveyMonkey link, and if folks could please fill that out by Friday, August 19th, to other folks as well, if there are colleagues that you think may not have received it. So that's it, just in terms of the MBHA, kind of a quick overview and kind of latest and greatest of where we are on our Fracture Prevention Central tools and resources. In terms of the webinar logistics, we will mute all the attendees during the presentations. There will be time for Q&A at the end of the webinar, which you can type in by going to your GoToWebinar panel. There is a little box that you can type your question in, and we'll make sure to queue up all the questions, and you can even start sending them in now, and they will be queued up at the end of the formal presentation. As with all of our webinars, we're recording this, and we will be able to put that up online on our YouTube channel and the Fracture Prevention Central by next week. So certainly look for that link, and we'll push that out as soon as that's available. And just wanted to introduce today's faculty before I turn it over to Dr. Lake and Leslie Stovall. So Ann Lake is the FLS Program Coordinator at Wake Forest Baptist Medical Center. Have worked a lot with Ann. She's great, very enthusiastic, very knowledgeable, has helped, I don't know how many, I don't know what the number's up to, but probably 50 or more FLS programs get up and running, as well as, kind of really address some of those barriers, challenges. So Dr. Lake received her doctorate in nursing practice 2011, and actually her doctoral thesis focused on implementation of bone health protocols and FLS in an orthopedic setting. She does serve as a consultant and clinical advisor to the MBHA, works very closely with the NOF as well, has spoken at a number of the meetings of the ISO, the NOF annual meeting, is also on the board of the North Carolina Osteoporosis Foundation, and certainly is a national and international speaker on osteoporosis and setting up FLS programs. She is also the author of the Metabolic Bone Health and Pediatric sections of the Orthopedic Nurses Practitioner Certification Review Course Curriculum. So our second speaker is Leslie Stovall, who is a professional coder, also at Wake Forest Baptist Medical Center. She is responsible for coding claims for the orthopedic department, as well as reviewing denials and providing reimbursement feedback. Has also assisted greatly in training programs for ICD-10, as you'll hear in just a few minutes, and is an advocate for provider education. Many years of orthopedic experience working in multiple areas of the practice. She is credentialed under the AAPC as a certified professional coder, and has also received a certificate of ICD-10 proficiency from the AAPC. She also, as I mentioned, serves as a reimbursement consultant to the NBHA as it relates to fracture liaison service programs. So with that, I will turn it over to our esteemed speakers. Thanks so much, and enjoy today's webinar.
Thank you, David, and good afternoon to everyone. As David said, my name is Leslie Stovall, and I am a professional coder for a large hospital facility. And we want to be able to to give you some tools today to help with coding and billing for your fracture liaison service. We've got some coding tips, diagnosis coding, documentation tips, information about the FLS program, and some updates. ICD-10 is here. We've all come through it, and it's been okay, it sounds like, from the majority of what I hear. Just a few reminders that I have to start with. Osteoporosis with pathological fracture coding has become much more specific with ICD-10. It includes the 7th character extensions, which I'm sure you're familiar with, at least these first 3. A for initial encounter, and that's going to be your active initial treatment or care. The D for subsequent encounters, and that's for pathological fractures with routine healing. Or S for sequela, and this was previously known as late effect in ICD-9. So now when we use a code with a 7th character extension S, it's never going to be your primary diagnosis code. This is always going to be secondary to what the actual problem the patient is having, whether it be a pain or a deformity, whatever problem is being caused by that sequela. So just keep in mind those S codes, the 7th character extension S, should never be used as a primary diagnosis code on your claims. Some other 7th character extensions that you might see, maybe not as often, are G, K, and P. G for fractures with delayed healing, K for non-unions, and P for malunions. And these are our refreshers. I'm sure everyone is getting pretty used to seeing these 7th character extensions now and all of ICD-10, how the codes are broken down. So let's take a look at some of the specific osteoporosis codes with and without pathological fractures. So osteoporosis codes without current pathological fractures, you've got your options there for age-related, localized, other. Of course, your senile or what we would have said post-menopausal, that's still okay for documentation, but that's all going to fall under your age-related osteoporosis now. And these are some just examples of the codes when you're not dealing with a current pathological fracture, when they don't have a current pathological fracture with that osteoporosis.
And just for clarification, remember that pathological can now be used as meaning osteoporotic fracture or a metastatic or pathological fracture related to cancer or some other issue. So keep that in mind, that don't be confused or shy away from using that pathological fracture code, or when you see it, osteoporosis with pathological fracture, just understand that that is connected to the osteoporosis when you're using that code now, that M81 code that she noted.
Yeah, that's good information too. Thanks, Anne. And for osteopenia, now with this code, other specified disorders of bone density and structure, it's broken down now into the specific site of the osteopenia or other disorder of bone density and structure. So for example here, now your code is going to look like M85.862, other specified disorders of bone density and structure. Then you've got your laterality, left, and your site, lower leg. So that was a big change for ICD-10 as well. Now, when you do have a current pathological fracture, and as Anne said, your documentation doesn't have to say specifically pathological fracture. That could be a lot of different, things there. But when you are dealing with the current pathological fracture and osteoporosis, your code is going to now include the site of the pathological fracture, of course, and it's going to require your 7th character extension, your initial encounter, subsequent encounter, is it a malunion? So your code's going to look like M80.1 M80.011A, for example, age-related osteoporosis with current pathological fracture. Then you've got laterality included as well, right, the site of the fracture, shoulder, and your episode of encounter, so your initial encounter for fracture. So that's just an example of what you'll see with ICD-10 and osteoporosis with pathological fractures. Of course, there are other osteoporosis with current pathological fracture codes as well, and these are also specified by site, laterality, and episode of care. So the example here is M80.822S. So of course, with this being an S, this code will never be your primary diagnosis code. If you're using a sequela, you're saying this is, the problem that they're having today is a late effect of this current pathological fracture, left humerus. And that can be, a sequela code can be used in any stage of care. So even if the fracture is not fully healed yet, but there's another problem stemming from that, you can use the sequela code. So there's an example of an other osteoporosis code with a current pathological fracture. There's some new updates, I'm sure everyone's heard, coming October 1st of this year. Two big things are happening among others, but the two big important updates that are coming. 1,900 new ICD-10 codes will be coming out on October 1st. Now, the total amount of changes are more like 3,500, with codes being deleted or revised. But actual new codes, there's going to be 1,900. The lists are not complete yet, but CMS does have a current revision of these new codes. And I've got the link for you here. You want to select the option. There are lots of file downloads on the cms.gov website under ICD-10 and GEM changes. But you want to select the addenda to see what's going to be new starting October 1st and what's going to be revised, any changes, and what's deleted. So you can at least take a look at that and get ready. Also, October 1st, 2016, the Medicare grace period for nonspecific codes is up. So they gave us a grace period from October 1st, 2015 when we started ICD-10 and said, okay, we understand we can't just jump right into this and be able to peg every single code. So as long as we were within the same family of codes, they're not denying claims. As of October 1st, we have to kind of move away from those unspecified codes as much as possible. And the only way we can do that is documentation. The documentation has got to be as specific as possible. And when you're thinking about documentation, the episode of care, is this active treatment? Is there something happening today? Or is it just a subsequent visit? You've got to think, is this disease process mild, moderate? Is it an acute situation? You've also got to think about any underlying conditions, like hypertension, for example. So when you think about specificity, those are the types of things that will help your coders and billers really drill down and get you the most specific ICD-10 code. And for osteoporosis, that's if you've got a current pathological fracture, it's going to mean stating the site of the fracture with the laterality. And if they've got osteoporosis, of course, is it senile, age-related, or is it localized? Is it some other type of osteoporosis? So whereas we've kind of been getting by with these unspecified codes, it's not going to happen, anymore after October 1st. I want to touch just a little bit on documentation for hierarchical condition categories. It's a risk adjustment model implemented by CMS that is currently used for Medicare Advantage plans only. So this is not subject to original red, white, and blue card Medicare, just the Medicare Advantage plans. And they're used to assign risk to patients. It's chronic conditions that should be documented in our records once every year. And there are over 10,000 HCC codes in ICD-10. Osteoporosis codes with and without current pathological fractures are included in those HCC codes. So if you do mention that or any other chronic conditions that the patient might have, and if you monitor the condition, evaluate the condition, address or treat the condition, you can code it. Or that code can be added on to your claim. Just for an example, if you're seeing the patient for maybe the FLS program, you're seeing them, you know, for osteoporosis or something along those lines. If you're reviewing records or you're speaking with the patient and it comes up that their COPD is stable on Advair, you know, if that's in your documentation, we can then add COPD as one of those diagnosis codes and get that coded for this year as an HCC condition. I've got some other examples for you here that are showing how you could monitor, evaluate, address, or treat. Of course, these are just examples. So insulin-dependent diabetes type 2, non-compliant with home insulin regimen. Of course, we'd be billing that diabetes code as well. GERD, patient is taking Zantac at times, or maybe you could say Zantac is helping at times, depending on the situation. Also a comment like long-term systemic steroid use for RA. Any of those statements added to your documentation, and you can bill that HCC code. And then I've got some clinical documentation tips, and these are all pulled from the CMS Clinical Concept Series. And this is for ICD-10. It's on the CMS ICD-10 website. And I thought they were really good, a really good group of documentation tips specific to ICD-10. So if you are seeing patients and asthma is an issue, for example, you now want to specify the cause of the asthma. And I've got some examples for you there. Is it exercise-induced, related to smoking? Is it occupational? You also want to specify the severity, and whether it's mild, moderate, or severe. And all these factors are going to get you closer or get your coders closer to that most specific ICD-10 code. So I've got some code examples here and how that criteria that you've chosen plays into the actual ICD-10 code. Here's a documentation tip for hypertension. Now you want to specify, is it essential, secondary? Having that in the documentation is very helpful, as well as any causal relationship. And I've got your hypertension code examples here. Osteoarthritis is another clinical concept guide that they have, that CMS has out there. This is one that I do see a lot. You have to specify, to get that most specific code, and that's the name of the game now, especially after October 1st, is being as specific as possible. You have to specify the type of osteoarthritis. Is it localized, generalized? Is it traumatic? And you also have to indicate the location and any specific joints, of course. And as many joints as you name, that's as many joints as is going to go on the claim. So I've got some code examples here as well. So M19.041, primary osteoarthritis right hand. Now, if we just left off that primary, if the primary osteoarthritis was not mentioned in the note, maybe it just said OA right hand, we would have to use an unspecified code, even though we have the site of the osteoarthritis. That's just how specific you have to drill down in these codes. So just leaving off one piece of information is kind of critical now. But that's why these clinical documentation tips and the guides, I've got a link for you here, they're so helpful because they have the clinical concept series in several different specialties. And a new code that came with ICD-10 is underdosing. Is it intentional, unintentional, or is it just non-compliant? Is the patient refusing to take their medication? And also the reason why the patient is underdosing is important when you're trying to code underdosing in ICD-10. So for example, your final code could be Z91.120, patient's intentional underdosing of medication regimen due to a financial hardship. And that's pretty important because that does happen. And that's a new code for ICD-10. So it's good that we can document that now and have that go out on our claims. So here I've got a list of the clinical concepts guides. They do have one for family practice, internal medicine, cardiology, OBGYN, orthopedics, and pediatrics. And like I said, that is on their ICD-10 website, CMS ICD-10. And I've got a link for you there if a simple search won't bring that up for any reason. And Anne, I think you could speak more to the fracture liaison service.
All right, so I'm going to let you flip through those slides, okay? So basically, obviously, people that are on the call are familiar with NBHA, the National Osteoporosis Foundation, and the concept behind the fracture liaison service. This is obviously to close the fragility treatment gap. So when you have an FLS service, your FLS service may be set up in many different ways or through many different specialties. Here at Wake Forest, our FLS service is driven and run through the orthopedic department, orthopedic specialty department. But in other practices across the country and in other institutions that I've helped develop FLS services within, they may take the approach of having the endocrinologist run the FLS service or a rheumatology specialist run the FLS service. Sometimes it's run through pain management. So I want everyone on the call to understand that any of this information will certainly apply to any of the patients depending on whatever specialty you're in. Sometimes the coding can get a little bit challenging. One thing that I will tell you that as a clinician, I am not just the coordinator, but I am the clinician for our service. So I'm in the trenches every day working on the electronic health records, and I know when a code pops up and tells me a certain lab isn't paid for or that I have to use another code, and it can be quite frustrating. So the main reason for this particular webinar is just to kind of get our minds wrapped around what are some of the common codes that we would see in an FLS service. You can go ahead and switch to the next slide if you'd like, and keep going to the next slide. I'm going to keep going through. Yeah, there we go. So again, the algorithm for an FLS may look something like this. And at Wake Forest, I can speak to our program where the patient is captured in the hospital, and they've already been given the code of a pathological fracture with osteoporosis now that we've been using the ICD-10 codes. So the orthopedic surgeon has already provided that code. Once the patient gets to me, I put a different helmet on. I still am thinking about the orthopedic patient and the bone healing process in that patient and the orthopedic issue, but I begin to think, what is causing the bone quality to be compromised? Is it truly age-related? Is it something that could be secondary? Secondary causes of osteoporosis are quite common. So when I see a patient in my FLS service, despite being in orthopedics, I really look at the patient from either a family practice standpoint or internal medicine or endocrinology or rheumatology standpoint, because I'm trying to look at the patient's whole medical history. So some of the common codes that you will see may not be the fracture codes if you're not in an orthopedic setting. In fact, I never really use fracture codes when I'm seeing a patient in FLS. I use common family practice codes. So the codes that pops up on my electronic health records, when I type in osteoporosis under visit diagnosis, it says M81.0. My documentation will reflect senile osteoporosis or postmenopausal osteoporosis or idiopathic osteoporosis or possibly just general osteoporosis if I'm going to do a workup on that patient. But the other common diagnosis that you will often see in your FLS program will be diagnoses that are common to family practice and internal medicine or rheumatology and endocrinology. Codes such as rheumatoid arthritis, because you're addressing the condition because it can affect the bone quality, what medications they're taking for that condition. Every type 1 and type 2 diabetic that's had a fragility fracture needs to have a bone health evaluation. Well, justification and the medical necessity of your visit is justified by what you code. So you need to use the diabetic code for that particular patient. You need to use that ICD-10 code for that patient. Even though you're putting osteoporosis as one of the codes, you also want to use supplemental diagnosis because you are addressing each of those conditions. And each time you address those conditions, those medical diagnoses that can potentially affect the bone quality of that patient, you're also justifying the visit that you're having for that patient. So it actually increases the level of the billing that you can actually do for that patient, because that visit now turns into from a level 3 visit to a level 4 visit, because you're looking at other disease processes that can certainly affect the bone health. Other common codes that you're going to see, in your practice when you see a patient and you do the workup on them and you do the lab work, you may not be sure about what their bone density is going to show. Maybe you got a patient that was referred to you that had a traumatic fracture, but because they're over 50 and they smoke and they're on reflux medicines and they've got a medical condition where they've had to be on chronic opioid use, maybe you're going to use F11.9, which is current chronic opioid use, which can also affect the bone. And then you do the workup on them, but you're not quite sure what's going on. Do they have osteoporosis because it was traumatic? So maybe you're going to use a code that's disorder of bone and cartilage, an M85.9 code. If they're coming back to see you and you've been treating them and they haven't been taking their medication, then maybe you're going to use that code for non-compliance for whatever reason. So again, this is really expanded beyond orthopedics in terms of using any kind of fracture codes. So think more along the lines, whether you're in orthopedics and you're running an FLS, or whether you're actually in a specialty and you're working with orthopedics to run an FLS program, think more specifically about the chronic disease management of these patients and the chronic diseases that will affect their bone quality, which led them to the fracture to begin with. Leave the fracture codes to the orthopedist. You really kind of don't want to mix the fracture codes in an FLS, especially if you're in orthopedics, because sometimes your visit can get kicked out. So you want to leave those fracture codes off. Leave those to the orthopedic surgeons or the post-op providers that are seeing the patient post-op for that visit, and focus more in the disease process that may be going on that's affecting the bone quality of that patient. So let's see. There's a question here, how does underdosing relate to osteoporosis? Well, underdosing relates to osteoporosis in the fact that the current research shows that a majority of patients that are actually started on any kind of medication for their osteoporosis treatment and management, especially oral medication, that usually a majority of those patients will stop taking treatment within 6 months of being started on treatment. One of the gaps in care in osteoporosis has not only been that we haven't necessarily captured patients, but the other problem is we haven't had appropriate follow-up with patients. So what we need to do is, if we're going to prescribe a medicine for chronic disease, we need to have appropriate follow-up, just like we would with diabetes. If we're going to start a new diabetic medication, or if we were going to start a new blood pressure medicine, we want to have that patient follow-up for compliance and to make sure tolerability is okay. And so you need to think about this concept in osteoporosis too. You want to think disease management, and I want my patient to be taking their treatment, because if they're not on treatment, their fracture risk is high. But if they're on treatment, we can reduce their risk by up to 50%, possibly 90% in certain areas of the body, based on some of the current research. But if we never follow up and we don't know if they're taking it, then that's a gap in care as well. So that's the reason that underdosing can be related to osteoporosis, because it has to do with compliance. Maybe the patient's embarrassed about financial concerns and they didn't want to call you. But it's really, again, about developing that rapport with the patient and building a trust relationship to let them know that their care is very important, and we want to keep them safe first and foremost. And keeping them safe not only includes giving them a safe treatment, but also making sure that we're not causing them undue financial strain as well. So that's a great question. You can go ahead and flip through the next slide. Yeah, so this is a good little tip. If you are in orthopedics and you're running an FLS, this is really more specific for those providers. If you have a patient that is referred to your FLS service and they are in the 90-day global period, which means that they had the fracture repair, and they're still following up in that 90-day post-surgical procedure. If you see the patient within that 90-day period of time, it is a billable visit, because you're a different provider and you're seeing the patient for an unrelated visit. You can use that modifier 24. Leslie, have you seen any problems at this point with claims being kicked out if the orthopedic surgeon is using the pathological fracture osteoporosis code with a fracture? If they're using that code and the patient is seen by a separate provider for osteoporosis, are you seeing any of those claims being kicked out because Medicare is not recognizing the osteoporosis as a separate visit?
Well, no, we've seen too many of those. But I tell you, you do need to use a 24 modifier for your osteoporosis workup, because it is separate. You're providing separate treatment than the orthopedist is for that fracture management. So if you did receive a denial, that's something that your documentation is going to back up. You can appeal that documentation, or even sometimes a phone call to the payer, explaining that this is an osteoporosis workup. Can get that resolved, even just sending in medical records.
Perfect. So that's why you don't want to use a fracture code in your osteoporosis visit, especially if they're in the global, because it can potentially get kicked out. But the main thing is use that modifier. I do have a lot of questions across the country that people have said, well, going forward, if we use that age-related osteoporotic code with a fracture, and the patient's had a fracture code as well, will we still get paid? And yes, the answer is you will get paid, because right now it is considered a separate visit because it has to do with bone health, not related to the fracture, even though the code is semi-connected to the pathological fracture with osteoporosis. So I think that's great. And we do have a question. It says, if I work within an orthopedic practice and my partner sends me a patient who is currently being treated for an active fracture, what osteoporosis code should I use for my FLS? If the patient had a fragility fracture, then you're going to use osteoporosis code. You're going to use a modifier, okay? And your visit, depending on your time spent with the patient, your visit will either be a level 3 or a level 4 visit. Now, all of my new patients that I see, they're established in orthopedics, but I'm seeing them for the first time, but they're established in orthopedics, so it's an established visit. I use a 99214 because I spend 30 minutes or 40 minutes with the patient face-to-face. So I use a modifier if they've had surgery. So to answer your question, if your partner sends a patient to you, and they've seen your partner that day for their fracture, and you get a referral, you can still bill for that visit. You're going to use osteoporosis code with a modifier, You're not going to use the fracture code. So hopefully that answers your question there. And then, of course, you want to use any other diagnosis that would support the reason that the patient could have compromised bone quality, if they're a current smoker, COPD, reflux problems, high-risk medication, seizure disorder, vitamin D insufficiency, at high risk for falls, any of those things that would put the patient at risk for compromised bone quality. So I hope that answers your question there. So next to the next slide. Okay, so yeah, so we've sort of put everything in a nutshell. And again, I think one of the things that I would encourage everyone to do when you're thinking about billing and coding, the very first thing that I would absolutely recommend that you do is, if you have any questions, make sure that you talk to your billing and coding specialist where you are. I can tell you there are codes, there are CPT codes that can be used in other areas, other parts of the country that we can't use here. We can use them, they're just not reimbursable. There are some telephonic codes that can be used that you can get reimbursed for. We can't do that here in our state. Medicare doesn't recognize some of those. But you want to maximize your billing potential for the time that you're going to be spending with these patients, and you want your documentation to reflect that. So the first people that I would certainly suggest is talk to your billing and coding people, and if you can't get questions resolved, you can certainly reach out. The other great tool that you have is to reach out to someone through the one-on-one consult through the NBHA to get a quick answer. A lot of times you can get it through email or whatever, but just don't let things like that sort of derail you. You want to take the word of someone who's been doing it and someone who knows what's been denied and what hasn't been denied, because you can get different things from different people across the country, and I think it's important, if you really want to have a successful and a sustainable FLS program, you absolutely want to make sure that your billing and coding is where you want it to be. You don't want to undercode, because you are going to be spending a lot of time on these patients, but you also want to make sure that if you're going to code a certain level of visit, that your documentation reflects what you actually did for that patient. So if you spent 30 minutes, you want your documentation to reflect that you spent that time with that patient, and 50% of your exam time was spent discussing osteoporosis, bone quality, bone strength, their bone density report, their labs, falls prevention, treatment management, treatment recommendations, and all of those things, to give yourself credit for that. If you have a template that reflects a 15-minute slot for a new patient, yet you document a 30-minute visit and you are billing a 30-minute visit, that sets you up for a possible audit. You want your template to reflect what your documentation reflects. So new patient visits, if you really want to give your patient adequate education and be able to get an adequate health history, 15 minutes is not going to be enough time most times when you're doing chronic disease management for osteoporosis, not for your initial visit. So you want to make sure your templates actually reflect the time that you're going to spend, so that you don't set yourself up for an audit. And again, use anything that will help justify the visit and also justify the patient's need for further workup. One of the little verbiage statements that I use in the HPI of the patient is I say why the reason they came in for a bone health evaluation, for secondary osteoporosis, secondary fracture prevention, osteoporosis, and treatment management for their bone health. I say that I've reviewed their chart, and then under their HPI, I briefly mentioned how they fractured, whether it was a ground level fall, a low trauma type fracture, and where it was, but that's about all I mentioned there about the fracture. And then I simply state, due to concerns for compromised bone quality and bone strength, patient was appropriately identified and referred for further investigation and treatment recommendations for improved bone health. That's the statement that will help justify the visit, to help prove to Medicare that we are giving better value of care with this visit. We are helping to reduce future health care costs by reducing future fractures, but most importantly, Improving the bone health of the patient is going to help improve their quality of life and help promote better outcomes, which shows that we are improving value. So Medicare is never going to not pay for a visit that's going to prove that, but you have to document that otherwise to make sure. There's a code here. Let me see if I can answer it for you. How do you code for patients being referred by ortho because they saw poor bone quality during elective joint replacement? Excellent question, but with no fracture. And if your patient is younger than 65, can we order a DEXA scan for her? I love these questions. Excellent questions. All right. Kudos. So answer to the first question is great because now we are going into bundled payments, and one of the things the American Academy of Orthopedic Surgeons has now been challenged to do is look at all your patient's history. If your patient has osteopenia on x-ray and you're going to put a joint in, you better think about a bone health evaluation on that patient. If a patient's had a prior fracture and you're doing a joint replacement, you need to think about that patient's quality of bone. If they're advanced in age, any situation like that. But if they are going to have an elective joint replacement procedure and there's documentation that says osteopenia, the patient has other medical conditions related to that, what you want to do is you can use the order of disorder of bone and cartilage, because that's true, they have arthritis, they're going to have a joint replacement, disorder of bone and cartilage, any other supporting diagnosis, and that will be able, you will be able to get the bone health evaluation completed, and you can get your bone density test done. Now, if you have a patient that's younger than 65, that question stems from the HEDIS measures that says that Medicare will only pay for a bone density test in a woman at a certain age and then a male at a certain age, and those are all preventative. But if you have a patient that's greater than 49 that's had a fragility fracture, you can get a bone density test on that patient, and you're going to be using the term osteoporosis because of the definition of a fragility fracture. If you have a patient that's less than 65 and they're postmenopausal, you can use the word postmenopause in females over the age of 50 and get a bone density test covered. If it's a male patient, if the male patient has diabetes type 2 or 1 or 2, if the male patient has hypogonadism, the male patient has thyroid disorder, any other COPD, reflux problems, any other medical condition that would predispose them to compromised bone strength, you can use disorder of bone density and structure to get that bone density covered, and you can also use disorder of bone and cartilage in that patient as well. We can get more specific. If you have more specific questions, I would again encourage you to reach out and do a one-on-one consult. I'm happy to be available if you need that, since I am in orthopedics, but there are other providers who certainly can answer those questions as well. But if I wasn't specific enough for you, I'm happy to chat with you later. I'm not sure where the question came from, who it was from, but happy to talk with you guys later. And it looks like, I think, Andrea, is that the last question that we have?
I think there's actually, this is Leslie, I think there's actually one more question in there. What code do you use? What code do you use for low vitamin D? Okay,
and that code I use is E55.9. That's the vitamin D code. That's vitamin D insufficiency. There is a vitamin D deficiency code. If the patient is less than If the patient is less than 10 to 15, I'm going to use deficiency code. I don't know exactly what the cutoff is, but I'll use deficiency if they're like that. But most of the time, it's going to be E55.9 for your vitamin D insufficiency. And if they have a history of low vitamin D, I usually put in my assessment, I usually say history of low vitamin D, and then if I'm going to order a vitamin D to get it covered, I'll associate it with the E55.9 because they do have a history, so I am justified to go ahead and get it and say that they still have that disorder. Once I get the results, if it's resolved, then you can put resolved in there. All right, so I think that's all the questions, and I'm so thankful to have all of you providers and clinicians and administrative people, whoever's on. I'm so glad you're on today, and I hope you found this helpful. I'm going to release it back to David or Leslie, and and we'll go from there. I hope you guys have a great upcoming weekend, and stand tall for osteoporosis and have a break-free future.
That's great.
I do see one additional question that just came up.
Okay.
Why not I'm going to butcher this, osteomalacia.
Yeah, that is. You can use that code if there's a vitamin D insufficiency. You could absolutely use that code. I mean, it's a valid code to use. I mean, that's absolutely true. So yeah, that is something. And especially if one of the physicians said, if one of the orthopedic providers said the patient had soft bone and they have low vitamin D and any other medical condition, nutritional deficiencies or anything that would be worrisome, I would absolutely not hesitate to use osteomalacia. So you would be fine to do that as well.
Gotcha. Well, thanks so much, everyone. Thanks to Anne and Leslie for a great presentation. And, as I said, we'll have this on-demand version of the webinar up very soon on Fracture Prevention Central as well as our YouTube channel. Feel free to keep the questions coming. And as Anne said as well, if you'd like to connect directly with her, Leslie, other experts around any specific questions related to implementation of your FLS, don't hesitate to go on Fracture Prevention Central, click on that one-on-one consult service section and fill out the quick survey, and we can get you connected with folks. And also would say, too, if there are folks coming to the ASBMR meeting next month in Atlanta, that there will be a couple of interesting talks that NBHA will be involved in, and we'll certainly push that out to folks before that meeting. So have a great day, have a great weekend, and we'll talk to everyone soon. Thanks. Bye-bye.
Thanks so much.